Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy Cancer Center. I'm also the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And my guest this evening is Dr. Sydney Brehany. Welcome, Sydney.
Thank you. Thank you for having me.
So Sydney is a medical oncologist with Mission Cancer in Blood, and we're going to get to know her a bit. And we're going to talk about everything to do with cancer and medical oncology and do some genetics and prevention and try to touch on everything.
Yeah. Wide roadmap, but we'll take it.
So welcome. Before we talk about cancer, let's talk about you. Where are you from originally?
Yeah, so I grew up in Algona, Iowa.
Gotcha. Kasuth County.
Kasuth County.
It's
yep,
the big one.
Mm-hmm.
The double wide or double tall county.
Double tall. Mm-hmm.
So how many in your high school class?
I think there were like 84, 85, something like that.
And what was your claim to fame in high school?
Oh gosh. I was kind of the one that did a lot of different things. So a lot of community events, band, sports, just kind of like across the board.
Music. Mm-hmm. So in a class of 80, you really get the opportunity to do a lot of things.
Yes.
So what sport was your dominant sport for you?
So I did basketball and volleyball. Volleyball was probably a little better.
Okay.
But I mean, you do them for, at least at that time in the world, I feel like you do them for fun rather than the intense competition.
And what instrument did you play in band?
I did clarinet. Okay.
And played in the marching band and the pep band and the...
Yep. Got to do all of it. Yep. With a small class, like you said, you got to do everything and everybody kind of knows who you are and what you're doing. And it's nice in a way. It's also everybody knows.
Yes.
So
no secrets. Mm-hmm. And then where'd you go to college?
So I went to Wartburg College in Waverly. Okay.
When you started college, what was your first declared major?
So I was biochem major the whole way.
Okay. So you did. And when you started college, it was with the idea of being pre-med?
It was not actually.
Okay.
So that didn't come until about halfway through college. I actually initially thought I was going to go into forensic science. That's the time CSI was kind of big. So I was really into that. And then that kind of fell off a little bit. Thought I was going to be a dietitian because I think nutrition and how we fuel our bodies is really important. And so was looking into that, and Wartburg offered a summer internship program out in Denver. So went out to Colorado for the summer, was supposed to be doing an internship with one of the nutritionists at the county hospital there in Denver. And through various series of events, maternity leaves for some people, just other people being on vacation, not available. They're like, oh, that's not available. So we're going to just stick you in the pre-op area and, have fun. So
you're in Denver and your internship is now in pre-op.
It is. I was stalking the little pre-op bays. Luckily, one of the anesthesiologists kind of noticed I was hanging around there a lot, and he was like, "Hey, do you want to come and see some stuff?" So, took me back kind of with the ORs and took me in a couple cases, and I was like, "This is actually really cool." And so, yeah, that was it.
So it was just kind of through happenstance.
It really was. Yeah. Because all of my friends at Wartburg were going pre-med, and I was like, nope, I'm going to do something different. I'm not going to follow the trend. And then here we are.
Okay. Well, great. And so you graduated from Wartburg, and then where'd you go to medical school?
So then I went to Creighton in Omaha.
Okay. And so we've talked about this. That's where I went to medical school.
Yeah.
So
small world.
Yeah, I went to medical school at Creighton from 1976 to 1980.
I was there a little bit later.
So
I'm sure Omaha was just a little bit different at that point in time.
I was moving to Omaha from a little town in South Dakota. So it was like, oh my gosh, this is like New York City. I was just amazed by how big Omaha was. And so what was your experience at Creighton?
So Omaha was definitely the biggest town I had lived in. So to that point. So it was a little bit of big city, but I have family in Des Moines. So we've been in Des Moines enough, and it was kind of similar. So it was nice to be somewhat close to home, not too far, but far enough type of thing. Omaha's a great city. I think it was a good place to be for medical school. Creighton, especially, you get some more of that personalized attention and just more opportunities to get involved in the community.
And you probably had students in your class from quite a few of the different 50 states.
Oh, yeah.
Not just Nebraska.
Yeah, I mean, a lot of people from California. We had somebody from Hawaii, East Coast. I mean, you name it.
Mhm.
There was, I don't know that we had Alaska, but
So in my class, we probably had something like 150, and I
Mhm.
think maybe only 8 women. And I know things
Yeah.
have changed dramatically, so I would imagine at least half your class, if not more than half
I
your
think we were
class.
just over half were women.
Mhm.
So
Yeah. So that
it's
would be a different experience. And
mhm.
what's some of your thoughts looking back on the training you had in
Mhm.
medical school? And what were some of the good things about training, and
Mhm.
what were some of the things that could be improved? I know that Creighton has completely revamped their
Right.
curriculum for medical school and has
Yep.
brought in more small seminar classes, more focusing also on the humanities and
Mhm.
kind of the interpersonal touch.
Yeah, and there's definitely a piece of that when I was going through. So we, had small group sessions. You'd have some of the priests come in and chat about different topics for some of that humanities piece. But yeah, they went from your first 2 years are straight lecture book work, and then the next 2 years are the clinical. And that, I mean, I think kind of diffusely across the country that's been changing.
Mhm.
So it is interesting to look at it now and be like, wow, that's not the same school I went to.
Mhm.
I think Creighton was great in the sense that you did have a bigger class. You got that diversity, but you still felt like you were at a small school, and you got that personalized attention. So, I remember I kind of had an interest in oncology at that time. And so, getting in with the oncologist, being able to chat with him one-on-one and be like, hey, research opportunities, service projects, things like that to really be involved. It was really nice to have that available and not feel like you were just another kind of number in the line type of thing.
And what spurred your interest in oncology?
Yeah, so I had been kind of all throughout my years growing up in Algona. Relay for Life was a big thing, and I had been quite involved in that.
American Cancer
Yep,
Society.
through the American Cancer
Major
Society.
fundraiser for the American Cancer Society.
Yeah, and it was a big thing in Algona. Like everybody came out for it. Everybody was looking forward to it for months. So very involved in that. And then when I was in college, Wartburg has a great science and research program. And so our biochemistry professor was doing some ovarian cancer research, and I got involved in that. So kind of had a couple experiences there. And then I think it's just, it's just an interesting field. There's a lot changing and a lot to still learn. But I mean, where we've been to where we are now, it's incredible just how far we can come, how much we can learn. So
yes, it's evolving, changing, probably faster than any field, and we'll talk about that. The path to get to be a medical oncologist is kind of a long path.
A little bit, yeah. Yep.
So you don't go from medical school right into medical oncology. You need to do a residency in internal medicine first.
Yep. So that was 3 years.
And where did you do your internal medicine residency?
So I went out to University of Colorado in the Denver area.
Okay.
Which was...
Did you hook up with that anesthesiologist and let him know that he became a doctor? Because
I think I came across his name a time or two because we rotated at the county hospital still, but I was not quite in the same departments he was, so not able to have that personal connection again.
So 3 years in Denver doing internal medicine.
Yep. And then another 3 years doing hematology oncology fellowship again in Denver. I just stayed at the University of Colorado for that.
And that campus, is that the Anschutz campus,
Anschutz.
Which is kind of, they built out of nothing, a brand new campus sort of in the western part of Denver, or?
It's actually in the eastern part. Yep. Okay. So it was the old VA Army Hospital was out on kind of the eastern side of this metro area. And that land was available, probably in the early 2000s or something like that. And yeah, they built the university hospital, the children's hospital is out there. All of the like medical research, kind of health sciences stuff, all of that's out there now. Even the new VA hospital is out there now. So it's just, you kind of drive along that road and it's like Hospital Row. But it's nice when you're training because then everything's basically right in the one area.
So oncology fellowship, and it
Mhm.
was hematology and oncology.
Yes.
How long was that fellowship?
It's 3 years.
Okay.
And you kind of split your time between hematology, benign blood disorders, and then the oncology piece, whether that's solid tumor or malignant heme.
And during your medical oncology fellowship, do you choose an area for research? Does everyone going through their fellowship have to do a research project?
So to some degree, yes. And I think it depends on what type of program you go to. Obviously, with the University of Colorado, it is an academic center, so there's a lot more academic leanings and ability to get in and do some of these type of projects. That being said, it's a really nice and supportive program because if hey, I want to go into community oncology, they'll still embrace that and set you up to be successful in that way. Still doing some, researchy type of projects, but more focused on the community side, whether that's quality improvement
In
or
clinical research as opposed to bench research.
Correct. Although, I mean, you can do that if you want. That wasn't not my
So
thing.
what was
but
your research project during your fellowship?
So I took a focus in hereditary cancer syndromes. And so my research project was looking at the population at our county hospital in Denver, so Denver Health. What was the uptake of genetic testing there for, I think, 4 different types of cancer that have very clear recommendations for genetic testing. Were these patients getting referred appropriately? Were they, because of the processes that we had set up, were they going to their referral appointments? Were they following through on testing? What was the likelihood of finding a mutation in our population? Because at that county hospital, it's a very diverse population, very different than I'm here in Iowa. So, are there differences coming up that, we just find because the population's a little different?
So you mentioned 4 different cancers, and coming from Creighton, there's a famous researcher from Creighton that really made a quite stake in the ground as it refers to hereditary cancer. Maybe talk a little bit about that.
Yeah. So Dr. Henry Lynch, I actually met him when I was in medical school.
He was one of my professors as well.
Yeah, he was an amazing guy. I remember sitting through one of his hereditary cancer consults and just being like, wow, like, so much. And also like the fact that he kind of built this arena of, cancer genetics and what we're doing today. It's so diffuse, but it's amazing.
Really. Yeah. And his background was really just taking good histories. So it wasn't, his background wasn't so much the science of figuring out how to determine all of the genes and do the sequencing of the human genome. It was more recognizing families where, especially colorectal cancer, was passed on or was present in multiple generations.
Yeah, kind of recognizing those patterns, which is really important. I think there's families out there that have a lot of cancer in their family, and nobody's really thought about, oh yeah, grandma had it, my mom had it, all my aunts and uncles had it, and now here I am. What do I do? So I think it is being talked about more these days, which is great, because the more we know, the more we can detect it. There's things we can do to help prevent cancer in those people that are higher risk to develop a cancer, which is always better to A, prevent it if possible, or B, catch it as early as possible so that our treatments are easier and more effective for the long run.
And because of research programs, so we know more about it, and the whole technology has changed.
Oh my gosh.
I mean, the figuring out the human genome initially took 20 years and billions of dollars, and now you can do a complete human genome sequencing in a couple of weeks for a few $1,000s.
Right.
And so it's become, number one, very fast to do the genomic, the genetic sequencing. Number 2, it's much less expensive. Number 3, we know the associations. And I would say number 4, we now have genetic professionals, even in comprehensive community cancer centers.
Right.
So the technology is available and offered to individuals.
Yeah. I mean, it's so much more accessible than it used to be. And I think the more the more that gets utilized and the more we're able to find some of these things, hopefully that means we're taking better care of patients and helping them live healthier lives.
So in 2025,
Mhm.
what are the situations, either the cancers or the family histories for individuals who are diagnosed with cancers, where you feel like it's the state of the art is this person should be tested?
Yeah. So I would say anybody with either pancreatic or ovarian cancer, those are automatic indications to be tested.
Regardless of family history,
Regardless of family history, regardless of
stage.
age, stage, any of that.
If you have pancreas cancer, ovarian cancer, should have genetic testing, because much higher than other cancers, that there could be a genetic mutation you inherited from mom or dad.
Correct. And there are things, if those mutations are found, that may guide treatment. So that's important as well for those cancers.
It changes the treatment as well.
It could.
Okay.
Yeah. I would say, breast cancer, there's some caveats there, kind of depending on family history, age, type of breast cancer stage. But over time, we've seen that or those factors become much more inclusive. So it's almost hard these days not to have a breast cancer qualify.
Mm-hmm.
So that one.
So we might, in the next few years, it may become standard that every woman with breast cancer maybe gets genetic testing.
Very possibly. I mean, especially with how accessible it is.
Mm-hmm.
It's easier to do. It's not something that we kind of have to almost gatekeep because of logistics. It's easy to do at this point.
So sticking with breast cancer for a second, what are some of the characteristics of a woman's diagnosis that might make it more likely that that she has a genetic pathogenic mutation that makes her more likely to develop breast cancer?
Yeah, good question. So age is a big one. If someone is diagnosed 40 or younger, that would be an automatic qualification for genetic testing. The type of breast cancer too. So in particular, triple negative breast cancer, where it's estrogen, progesterone, and HER2 negative, that's also a quick indication to do genetic testing, just because that type of breast cancer can be associated more likely with one of the common mutations. And so again, we like to know up front because it may impact what that woman chooses to do for her treatment. Additionally, if there's a strong family history, so if their mom also had breast cancer, their aunt, their grandma, you name it, the number of family members you have to meet that piece of it is decreasing. So
and then we often talk about first degree.
Right.
So a first degree relative, either your parent or a sibling or a child.
Yep. So if you have first degree, that's a pretty clear indication. If they're second or third degree, so aunt or uncle, grandparents, cousin, things like that, you typically need more relatives with that type of cancer or a related cancer. We're not in a vacuum when we're talking about these cancer genes. So for example, there's genes that breast cancer, ovarian cancer, prostate cancer, pancreatic cancer can all be associated with the same gene. So when we're looking at families, we're saying not only, oh, is there a lot of breast cancer in this family, but, oh, hey, we've got this 50-year-old who has a breast cancer. Oh, her mom or her aunt had an ovarian cancer. That triggers an association in our mind.
Well, maybe call out and name some of the pathogenic mutations that predispose to breast cancer. Yeah,
so the common ones people know about are the BRCA mutations, BRCA1 and 2. And I think those have been the most publicized. And, Angelina Jolie had her whole public mastectomies and all of that several years ago. I think really brought light to genetic cancer syndromes. Other ones that are not quite as talked about, but we can see like PALB2. With ovarian cancer, there's some RAD mutations that can occur, ATM mutations. So, there's a few different ones, and to what degree people recognize them as opposed to the BRCA, just because that's so.
Right. What are some of the risks, when we always talk about the risks and benefits of doing things in terms of genetic testing? Obviously, the benefits are that if you learn that you have a genetic mutation that you inherited, some of the benefits are that that information might lead to other family members being tested, and we might actually do screening at an earlier age, and sometimes it can actually affect the treatment that you get for the cancer you've been diagnosed for.
Yeah.
What are some of the risks
Yeah.
of undergoing genetic testing?
Yeah. So, the test itself is just a blood test. So aside from being stuck for a lab draw, the actual test itself, low risk. The implications of it, though, I think there's a few things people like to or should think about. One, is that person ready for that knowledge? Because it can be a heavy burden, a heavy diagnosis to learn, oh, I'm at, a super high risk for breast cancer or ovarian cancer. Some of these mutations, your risk for breast cancer of your lifetime is close to 80%, which is significant. Not that it guarantees you're going to be diagnosed with a breast cancer, but that's a big thing to carry. And so making sure that person is aware of the implications of testing and what that means before they do it, I think is a big thing. There can be implications if someone is looking at, say, life insurance, disability insurance. While there are protections against genetic discrimination for health insurance, the life insurance, disability insurance, long-term care, those are not protected as well. Right. So sometimes people, and I've had these conversations with people, they're like, no, I want to wait on testing because I want to get those insurance policies in place before I figure out whether I have this or not. In people who have been diagnosed with cancer, that's usually not as much of a concern because the cancer diagnosis usually trumps any genetic mutation that's found in terms of, insurance qualification. But it can be a
having breast cancer is going to affect the rates for buying life insurance. But as you pointed out, with the Affordable Care Act and other laws that have been passed, they can't change your health insurance premiums.
Correct.
Can't deny it, can't raise your premiums based on your own cancer diagnosis or a genetic predisposition.
Mm-hmm. Yep, correct. Okay. Correct. And then, I think recognizing the implications for your family. The way these genes are inherited, you really only need one bad copy to be at risk for the various cancers that could come with it. So we all have 2 copies of each gene in our body. If one goes bad, the risk for cancer could go up. So
you think of those of us who might have taken basic genetics of dominant and recessive, and
correct.
That if it's a recessive mutation, you have to have both of them to end up being, I don't know, blue-eyed, but the brown-eyed is dominant. And
yep.
But with the cancer ones, they're almost all dominant.
You
only have you
just
one
need
copy
one copy
from either mom or dad.
Correct.
Okay.
And so what that means is if you do have one copy, if you have children, each of your children is at 50% chance to have the same thing. And it does matter what the mutation is as to, when we would recommend testing other family members, particularly children. Because sometimes, if it's like a Lynch syndrome gene or something, then maybe we would recommend testing kids younger. But if it's a BRCA gene, we don't really have anything we can do for kids, say if they get diagnosed at age 12 or something. So that can be a heavy burden to put on a child if we're not going to do anything about it.
Right. And the doing, so if you find out at age 20, so you've got a family history, and let's say, your mom had breast cancer and actually did genetic testing and has the BRCA1 gene.
Sure.
When a young woman finds out, what would we recommend doing to try to help reduce the risk of her ever dying of breast cancer?
Yeah. So for breast cancer, it's nice because we do have screening available. And when any one person starts screening kind of depends on their family history and how old they are when we do testing. Especially if family members were diagnosed at younger ages, say in their 30s or something, if they present at 20, 21, 22, maybe we start screening earlier. And that typically includes breast exam regularly, and then combination of mammograms and MRIs for the breast. And typically once we're in kind of that full force of screening imaging, that's a breast MRI once a year and a mammogram once a year and clinical breast exams.
So it's screening at an earlier age and more thorough screening.
Correct.
Including MRIs, which isn't considered a typical screening.
Not yet
device.
anyway.
Yeah. Yeah.
Yep. In addition to that, because we have screening, it's not a firm recommendation or, even anything that someone has to seriously consider. But, some women do choose to do prophylactic mastectomies to remove all of the breast tissue to reduce their risk of contracting breast cancer. Unfortunately, it's not perfect. I've seen women go through all of that and then we're still treating a breast cancer.
Right. Even when you have a mastectomy, the breast is not like a kidney that has a capsule around it and you remove the entire kidney. There is breast tissue that goes up under the skin quite a ways away from the main mound. And so even having a modified radical mastectomy, not every bit of breast tissue is removed.
Right. I think the surgeons do great things these days, but, unfortunately, it's just one of those situations we can never say never, no matter how good their surgeon is. So in those cases, even if someone does have a mastectomy, I will often still offer them breast or chest exams, just in case there's any nodular tissue that shows up kind of along the incision lines or something feels off.
So I've seen a common practice to be a young woman's been found to have the genetic predisposition that the lifetime risk is 80%. The risk in the next 5 years isn't 80%.
Correct.
So sometimes a young woman might make the decision to, if they want, she and her partner want to have children, that they have children, do the breastfeeding, have as many children as they want to have, and then wait till after they're done having children and doing breastfeeding to do the prophylactic preventative mastectomy after that.
Right. And, this is where knowing your patient and having those life conversations is really important, because people with genetic diagnoses, it's not just their risk of cancer and these organs that we have to deal with. It's the whole person, and especially the reproductive concerns. When we're talking about BRCA, it does involve ovarian cancer, and so there's recommendations to have your ovaries and fallopian tubes removed, and at what point that's A, appropriate, and B, someone's ready to do that in terms of their family planning and such, is really individual.
Sometimes you hear manifestations of kind of simplistic thinking, and a woman has breast cancer, has a BRCA gene, and goes, okay, I got to get my daughters to get tested. Why is it important that the sons also get tested?
Yeah. So it's, it's not just a female condition. Men can inherit the BRCA gene as well. And male breast cancer does happen. It's not common, but there is a risk for it, especially in patients with BRCA mutations. So there is screening that comes along with that for men. Additionally, as I mentioned, we're not in a vacuum with one gene equals one cancer. So with the BRCA genes, we're looking at pancreas cancer, prostate cancer, which is a big one for men. And with BRCA2, there could be a little bit of increased risk for melanoma. So there are other things outside of female health that need to be considered and looked at. So men definitely should not put it off and say, oh, nope, that's my female side of the family. And two, that man may go on to have a daughter.
Right.
And so it just perpetuates.
So we talked about breast cancer at the outset. We also talked about pancreas cancer and ovarian cancer. Maybe focus a little bit on Lynch syndrome and colorectal cancer. That's another one of the 4 big cancers where we see a reasonable amount of genetic mutations that play into the risk, enough so that we do quite a bit of genetic testing for families that have colon cancer.
Yeah, and the recommendations around who gets tested for colon cancer have really evolved in the last couple of years. So, now that's kind of anybody with a diagnosis of colon cancer could qualify, regardless of family history, regardless of age. They've kind of opened it up, which, I think, again, because testing is so accessible, it just makes it easier. And, honestly, on the clinician side, one less thing to have to remember what the actual qualifications are. It's just like, oh, you have colon cancer. All right, let's have you talk with the genetic counselors and see what you're thinking about testing. So, Lynch syndrome, there's 4 main genes that are with that, PMS2, MLH1, MSH2, and MSH6, which I know is alphabet soup for most of us. But if you have one of those gene mutations, it may impact treatment. In patients with those gene mutations, we see that immunotherapy tends to work better. And so maybe there's a
better than chemotherapy.
So maybe there's a chemotherapy-free plan we can
Mm.
come up with for
Mhm.
them, post-surgery if they're an early stage or.
And it also might affect how much of the colon the surgeon removes.
Correct. And there, I mentioned those 4 core Lynch syndrome mutations. There are other mutations that predispose to colon cancer. So say someone has like an APC mutation, that would definitely impact, to me anyway, how much colon they should remove, just because the risk of more polyps and a future cancerous polyp is much higher. In some of those patients, they may have a prophylactic colectomy, getting their colon taken out prophylactically to hopefully prevent a colon cancer from happening. So, there are, in addition to kind of medical treatment, there are surgical implications of these mutations as well.
And then one more that I just want to talk about, because
Mhm.
I've been involved with the care of a couple of patients. And before that, I wasn't aware of this. And that is a genetic mutation that leads to stomach cancer, to
Mhm.
the extent that people have their stomach
Mhm.
removed as a prevention.
Yeah. The diffuse gastric cancer syndrome, which I think is CDH1, that's a tough disease. Stomach cancer in general is tough, but when it's that diffuse type and genetic association, that's a tough thing. And so, yeah, I mean, it is something where people have done the prophylactic stomach removal to reduce their risk, which seems like a large undertaking, and it is. That surgery is huge.
The
but
2 that I've been involved with, they had a genetic mutation, they had their stomach removed, and they did find cancer in the stomach, even though it was
Yeah,
kind of hidden there.
I've heard those stories too. They did the endoscopy, didn't see anything. It was just kind of prophylactic thing, and it's like, oh, actually, I did have a cancer. So it was though it was done as preventative, it was actually therapeutic, and probably good they did it, because otherwise it would have been found in a much later stage and harder to treat at that point.
Yeah, and that's really the hope, is that with genetic testing, we do screening, we do sometimes surgeries that might prevent the cancer, removing ovaries, removing breasts, removing stomach, as that we will ultimately reduce the death rate and have fewer deaths related to cancer, because we are better equipped for doing screening and treatment that's appropriate for that patient who has that genetic mutation. Right. And then also look out for their family members.
Yeah. I mean, some of these hereditary cancer clinics, you get to know the whole family. You see generations and generations of them come through, which I think is really cool. But it's an undertaking.
Let's talk a bit about, shift gears with talking about all the new drugs. I don't know how you guys keep it. So I was trained as a radiation oncologist, and in all honesty, we haven't invented any new radiation. I mean, there's some new techniques and some new machines, but we really have not invented new alpha particle, beta particles, X-rays, gamma rays. We haven't invented.
Does physics even let you do that?
We don't. Yeah, that would be universe altering,
Yeah.
So, but in terms of medical oncology, which, kind of in the essence of its name, is using medications to treat cancer. And we only have about 15 minutes left, but maybe talk about the general categories of the types of medicines. And then I just am really interested is, how do you and your colleagues keep up on all of the changes? There's never been a time in all of the world history where the number of new drugs that are coming out every year.
Yeah, I feel like I get emails every week with new indications or new drugs that are coming up. So yeah, I think when people talk about medical oncology, or they're going to a medical oncologist, I think number one, they're like, oh, chemotherapy. I'm going to be sick. I'm going to lose my hair. I'm going to feel awful. Going to look skin and bones. And I think in the past, that was the case, because that's what we had to treat people with. Now chemotherapy is one tool in our bucket. But even then, if we're using traditional chemotherapy, we've gotten so much better at the supportive care around it and how to manage some side effects that, people are not stuck in the bathroom for days and days. They're not wasting away in bed. They're able to, continue living their lives. Maybe they're not feeling as great.
Work.
Yeah, they can work through chemotherapy. You may not feel the greatest for a few days, but it's a more manageable thing than people have that image in their head.
And
I
that's
think.
that's traditional chemotherapy, which are
Yes.
medicines that kill cells that are rapidly proliferating.
Rapidly dividing. Yep. I think the downside to traditional chemotherapy is, it's given through an IV. It goes all throughout your body, and while it kind of targets the cancer cells because they are rapidly dividing, it doesn't discriminate cancer cell versus normal cell. So that's where all the side effects come in. And depending on what we're treating with, is going to give you the side effect profile we're looking at. I think excitingly in the last several years, more drugs in the immunotherapy category, the targeted therapy category, really the immunotherapy category is just ballooning in terms of.
Maybe talk a bit about immunotherapy.
Yeah.
How would you define immunotherapy?
So at its core, I would say immunotherapy is medication with the goal to enhance your own immune system or kind of trigger your own immune system to go find and fight cancer cells.
So the medicine that you're given doesn't kill the cancer cells. It kind of revs up your own immune system to kill the cancer cells.
Yep. It's like the cancer cells out there with the sign that says, I'm good, don't kill me. And the immunotherapy takes that sign away. So then your immune system can see it and be like, oh yeah, there's the bad guy. Let me go get him. There are a lot of different drugs, kind of subclasses within that immunotherapy category. So, kind of the base of what I think of when I think immunotherapy are drugs like Keytruda or Opdivo, Tecentriq, some of these medications that do remove that stop sign from your immune system. But you could even put into the immunotherapy category, CAR T cell therapy, tumor infiltrating lymphocytes for different tumors.
Talk about CAR T, because that's happening, and it's going to be available more and more at comprehensive community cancer centers, not just
the academic
comprehensive
centers.
academic centers. So talk about CAR T.
Yeah, so CAR T is really cool. What it is manufactured T cells, which are a type of immune cell that our bodies make. We extract them from the patient and then engineer them, kind of grow them in the lab and infuse them back in the patient. There's also, this whole protocol that goes along with it. There's chemotherapy involved to get them ready for the infusion when they get it back. But really, those revved up T cells are then going in and they're hardcore ready to go fight cancer cells.
So you take out, let's say I'm the patient, you take out my T cells, you send them off, you grow them, but then do you teach them how to kill my cancer?
Yeah,
it's like sending your dog to hunting school, and so it's not only do you multiply the dogs, but then you teach them how to find the cancer cell in me.
Yep. We kind of engineer or train them to recognize certain markers or express certain markers, and so that's what they're going to go after.
Gotcha.
So say we're using it in a lymphoma, we're training those T cells, to go look for certain markers that lymphoma has, and then when they find those cells, they attach and they they go to work.
Grow more of my own T cells. You train them how to find my cancer cells, and then you infuse them back into me.
Correct.
Okay. And what do the initials stand for? CAR.
Yep. So it's chimeric antigen receptor T cells.
Okay.
And so that receptor is kind of what we're engineering and teaching those cells to recognize. T cells are just type of immune cell that are very active and can go find and fight.
Currently, what types of cancers are currently approved for using CAR T, and where do you see CAR T going beyond the current indications?
Yeah, so really focusing on the blood cancers at this point. So certain types of leukemias, various types of lymphomas, myeloma also has indications for it too.
Okay.
And I think, those indications are expanding day by day. So, will we see them in solid tumor? Probably at some point.
Yeah.
Yep.
And by solid tumors there, we're talking about breast cancer, prostate cancer, colon cancer, lung cancer.
Yep. I think what we're seeing in the short term, though, is initially these treatments were looked at kind of in later lines of therapy. So someone, say they have a lymphoma, someone's gotten chemotherapy, they've gone through a stem cell transplant, they've had more chemotherapy, and then we pulled out CAR T to see if that would work. And it does well, it got approved, and we're moving it up in the sequence of treatments. So, it very well could be that we're looking at more first line, or we do some induction chemo and then, CAR T treatment right after that to hopefully drive better responses and longer sustained responses.
One thing people often think of stem cell transplant as like this dramatic, really out there new treatment, but correct me if I'm wrong. I mean, stem cell transplant is not the stem cells that kill the cancer cells. No. It's just old-fashioned chemotherapy in doses that are strong enough that it would kill the patient in addition to the cancer.
Yep.
So it's kind of an old-fashioned treatment in terms of the drugs that actually kill the cancer cells. You just get the stem cells so you survive a lot of old-fashioned high-dose chemotherapy.
Yep. I view it as, exactly that. It's the stem cells are a rescue to allow your body to survive the intense chemotherapy that we're throwing at you when you have some of these diseases. Like you said, it's been around many years. Interestingly, they were looking at it for solid tumors at some point. I had a mentor in fellowship who, when she was going through fellowship, they were doing stem cell transplants for breast cancer.
Yes, for stage 2 and 3 breast cancer. Yes, I was involved in that as well.
And I've seen in my fellowship, we were doing it sometimes for testicular cancer patients, just to get them enough chemotherapy to get a good response, and then rescue them with those stem cells.
One of the things that we have seen in the last 10 years, when immunotherapy was first started, I think we thought, well, it just controls the cancer. It doesn't cure the cancer. It just controls the cancer. But now, I mean, with melanoma, we've all seen stage 4 melanoma that before immunotherapy, 99% of those patients would die of their melanoma. And then when we found success with immunotherapy, we thought, well, you probably have to be on the immunotherapy forever because it's just sort of keeping it under control. And now we have lots of patients that have stage 4 that had immunotherapy, the cancer went away, and we actually stopped the immunotherapy, and it hasn't come back.
Right. Which those responses are amazing. Especially, you highlighted melanoma. To me, that's one of the worst cancers, just because it can happen to anyone. It, can happen anywhere, and it can come back anywhere in your body. So it's hard to treat because traditional chemotherapy has not been successful for it. So in those patients where, immunotherapy is effective and we get those long-term responses, it's amazing. Same thing. I've got some patients who have small cell lung cancer that have metastasized, which, we know is a bad disease. They're going on 4 years later. They're doing great because the immunotherapy has just taken care of things so well. It's really amazing. And I think, the more options we get and the longer we're using immunotherapy, maybe that changes the paradigm of stage 4 cancer is incurable.
Yes. Hey, one more question before we turn it over to the audience. And this is also something that has really changed the way we treat some cancers, and in particular, some lung cancers. So, we still know that cigarette smoking is the number one modifiable risk factor that causes lung cancer, but that there are many individuals who never smoke who get lung cancer.
Yeah.
And many times women who have never smoked who get lung cancer have a higher likelihood of having a genomic mutation of the cancer cell. So not a gene they inherited from mom or dad, but a change in the cancer cell. ALK or EGFR, just two of maybe 17 or 30 different ones. Maybe talk about targeted therapy in the situation of a non-smoking woman with a EGFR mutated lung cancer.
Yeah. So in non-smokers, like you said, those driving mutations are more prominent. And really it's helpful when they have one, because that opens up so many different treatment options for us. In lung cancer particularly, there's so many different driver mutations. It's it's hard to keep track of all the driver mutations we're finding, and then even harder to keep track of all the
Right.
drugs that we've developed against them.
And saying this again, these are mutations in the cancer cells,
Correct.
not the mutations in the genes that
It's not
we
something
have
you're going to inherit
or pass on.
Correct. It's just something that has happened in the development of the cancer, not a hereditary thing. But it's great because we have these drugs that target that mutation specifically. So you're really targeting the cancer cells more than the rest of the body, which gets around some of those side effects that can happen with more traditional chemotherapy where it's going all throughout your body. And we've seen great responses with this. Some people are able to go into a great remission and they just stay like that for many years, which is kind of unheard of, especially lung cancer.
Yes, for stage 4 lung cancer and have a 8-year survival or 10-year
Right.
survival.
It's amazing. And especially when, we're seeing some of these people diagnosed in their 40s, their 50s, no smoking history. It's kind of like, man, this is awful. But if we are able to find one of those mutations and get them on these drugs, you get a good response. It's a really rewarding experience.
Great. Well, thank you. And now we're going to open up the audience. So we've got a live studio audience. They get to have first questions. If you are watching us live streaming right now, you can put your question into the comment section of the software that you're using to watch us. So up first, Poon.
Yes. People have received chemo and they have, that goes all over your body, like you said. And then they have side effects like neuropathy and chemo brain and so forth. Has there been any research that shows that these eventually gets better?
Yeah. So some of those side effects you mentioned in particular, the neuropathy, the chemo brain, those are tough because there's no great way to prevent those necessarily. Things like nausea, vomiting, diarrhea, we can prevent those easy. We've got a lot of drugs for that. Those more neurologic type side effects that you're mentioning, those are just harder to prevent in general. I think the biggest thing to help avoid those is checking in with the patient frequently and being like, hey, are you having any of these things? Because maybe we need to dose adjust or modify what we're doing, especially if it's someone with a stage 4 cancer where treatment's kind of for the long term. We want to be very mindful about what those side effects are and what that means for quality of life. Because in addition to getting people more life, we want their life to be worth living and, to a quality that they're happy with.
So Sydney, in terms of peripheral neuropathy that Poon asked about, have there been studies that show whether the cold mittens and the cold booties reduce the chance of a patient getting chemotherapy will have peripheral neuropathy?
So there have been studies looking at that. And depending on the type of chemotherapy that we're giving, it could be something that we offer. I think it's kind of mixed, the results on that, but it is, if the patient's up for it, it can be worth it to try. The tough part is it's uncomfortable to sit through because when we say cold booties, cold caps, cold mittens, we mean cold, to really reduce that blood flow.
Right. Wait a minute. So patients who are getting oxaliplatin is one of the drugs that can cause peripheral neuropathy, correct?
It is. Yep.
But isn't that also a drug that causes cold insensitivity?
Yes.
Where you're not supposed to be handling cold. So how does that work if the treatment, it seems like it's contraindicated to
you. So patients who are getting oxaliplatin, I don't offer the cold mittens and such, because that cold neuropathy is often significant. Yeah. And so more so like if a breast cancer patient is getting a Taxol medication, that's kind of the situation I'll think about it. And where more of the data is. Some of these other medications, it's not as pronounced, or like you said, could be contraindicated because of the other side effects that it can cause. And, I mentioned being in good contact with your oncologist as you're going through this treatment. Some of the drugs, like oxaliplatin, for example, that cold neuropathy is going to happen right away with cycle 1, but it should go away after a couple of days. And some of the neuropathy that can develop more in the fingers or toes is something that happens later down the line. So we can often get a ways into treatment before we're really dealing with neuropathy that is at risk of being a longer term issue.
And Boone didn't ask about it, but hair loss is a side effect of some chemotherapy agents that can be particularly troubling to patients. And so there is a technology of cold capping. And again, the theory is that if you make the scalp really cold, there's less blood flow. So maybe the hair follicles will get a lower dose of chemotherapy than the rest of the body. Has that been shown in trials to really work? And if so, how and when is that offered to patients?
Yeah. So there are trials looking at it. It can work. In my practice, again, it's kind of more of the breast cancer population with that Taxol drug in particular. But even some other chemotherapies, we'll try it. My experience with it is if someone is really motivated to try, we'll try it. Like I said, it is uncomfortable to wear that because you have to wear it the whole chemotherapy infusion. And depending on how long your infusion is, that could get really cold. It works for some people. It doesn't work for everybody. I would say there is still some hair thinning that occurs regardless of whether you do it or not. And to what degree somebody experiences that is kind of individual as well. So it's not perfect, but depending on what any one person's motivations are and goals are, it could be something worth trying.
Okay. Next question, Ron.
I know most treatments are administered through an IV, and you hear more and more about some other ones that are using pills.
Yeah.
And say something like Keytruda, which I believe the infusions are every 3 weeks. Is there any research going on that might look at a pill?
Go into a pill. So I don't know that something like Keytruda specifically would go to a pill just with the way it works. Some of these mechanisms were kind of stuck with one route of administration. Yeah, I will say, some of the immunotherapies were getting more injection rather than the infusion that you're sitting there. So you could come in, just get an injection and say your thigh or your arm, that's your immunotherapy rather than being hooked up to the IV for a half hour or whatever it is. So there's some of that modification coming. But I would anticipate that, some of those medications that have been traditionally IVs are probably going to be still given through a needle of some sort rather than being converted to a pill. But, the future is always bright, and
one of the
we'll see what happens.
Potential advantages of an injection is that it could be given at home
Eventually.
and or even self-administered.
Right. And I think some of those things, may come down the pipeline. I think we'll see kind of how, unfortunately, the insurance companies are a big part of cancer treatment too. We'll see how they end up liking some of those ideas. But that would be nice, if we can just give you your injection, especially if we can give you like 3 months at a time and you don't have to come see us that frequently, it'd be nice.
Okay. George.
A question from a viewer watching on Facebook tonight. A good question for both of our doctors. Dina asks, what are your thoughts on CT scans in long-term testing for those in remission as far as the radiation exposure? Minimal for each scan, but over years and years, when stage 4 in remission, should CT scans be limited?
Yeah, I think, it's a situation where if we're talking about a stage 4 patient, we really have to take the whole situation into account, kind of look at everything. Because I do want to weigh the risk of radiation and potential complications from that with the benefits that we're getting by monitoring the cancer. We don't want to completely forego scans because what if something changes and we don't catch it early enough and, things kind of get too activated with the cancer. So there is a balance between it. I would say for the most part, my practice has been, especially if we're just starting treatment or things are kind of active or we're having some change, about every 3 months is what I kind of balance out as. And then, yeah, some of my patients, like I mentioned, they've been on treatment for years. It's like, well, we probably don't need to scan you that often because your cancer has demonstrated that you can be stable for long periods of time. So we'll talk about spacing things out. Maybe we go 4 months, maybe we go 6 months, something like that.
Yeah. And I would agree with that. It's always about risks and benefits. And one thing I would just say that would put ease at some people's mind, but especially if we're talking about stage 4, and if we're talking about a stage 4 cancer that right now we think is treatable but not curable, it is true that radiation exposure can increase the risk of causing other cancers. But the cancers that radiation is going to cause typically happen 20 years later. So reducing exposure during a few years of a patient who has incurable cancer, who's likely not going to live 20 years, that's probably the risks are low. But the point is well taken. Let's say patients, a different category of patients that have been treated and have had a complete response and appear to be cancer free. There, if you were to do scans every 3 months or 6 months, or even, at what point do you stop doing scans or do them at less frequency? Because there is no doubt that both, ironically, chemotherapy and radiation therapy can cure cancer. They both can cause cancer. Yeah. And we know that having a second cancer or a third cancer is a real possibility. And that doing too many scans can increase the risk. So it's appropriate for patients to ask their doctors, do I really need to have it every 3 months? And as Dr. Brehany said, if they're far enough along and their cancer is stable and it's never really recurred quickly, sometimes you make the decision, let's monitor by symptoms, and we'll hold off on scans unless you're having symptoms, or we'll only do them every 6 months. So it's good to have that conversation because stage 4 cancer is an art, and you're guaranteed with stage 4 cancer that you're going to change the treatment at some point. And you change the treatment either because the treatment's not working or the side effects are too tough. Right. So those are really good conversations for anyone who is living with cancer to have good conversations with their medical oncologist about, the frequency of screening and also about the side effects of treatment. Yeah.
Final question here in the 21st century. We're talking about, I still talk to people, maybe older demographics, but still recoil in horror at the term chemotherapy. Yeah. I mean, to a lot of people, it means maybe not a death sentence, but you're going to wish that you were dead. Is there education programs that are changing for people? Are we overcoming that, or what?
I think we're making a little inroad. I think it depends on who you talk to and what their experience has been. I have some patients who say they're in their 50s or 60s and they're like, my mom or my grandma went through chemotherapy in the 80s or 90s and it just looked awful. And I'm like, yeah, it was awful back then. But, really having a conversation with those patients, being like, this is what you can expect these days, because we've made so much progress in terms of how we manage nausea, how we manage infusion reactions, even what chemotherapy we give and what combinations and the doses, because now trials are looking at how do we decrease the amount of chemotherapy we're giving, not just throwing the kitchen sink at people, but can we tweak this a little bit so we're giving even less chemotherapy than we did in the years past. So anytime someone is doing chemotherapy with our clinic, we have them do a chemo teaching session where they get in depth about all of those logistic side effects, how to manage this, what supportive medications are out there. So hopefully they go into their first treatment kind of armed with all the information they need to help manage anything that might come up. But I think, it's hard with the general public kind of having those thoughts to sometimes break that until you're really going through it yourself. And you're like, oh yeah, this is not what my grandma experienced.
And as Dr. Brehany pointed out, there is the old-fashioned chemo, but there are targeted therapy and immunotherapy. And a lot of times patients just put that all in the same category. So they might be fearful of the chemotherapy. Well, they might not even be getting chemotherapy. They might
Mhm.
be getting immunotherapy or targeted therapy. So
Mhm.
it really deserves a conversation today. And
Yep.
our time is up. So thank you,
Yeah.
Dr. Sydney Brehany,
Thank you for
medical
having me.
oncologist with Mission Cancer and Blood. And we'll definitely have you back again.
Great. I look forward to it.
If anyone watching this program this evening knows someone that would benefit by watching it, it will be available on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel and the Mercy Cancer Center website. I hope you'll join us again next week. Thanks, everyone.
Thanks.